everyone, it's Sister Pinky. I'm back with another video, and today's topic is negative pressure wound therapy. So this is a type of dressing that we use connected to a machine. As you can see at the far bottom right, there's a small machine. That machine has batteries, but we often use bigger machines that would need to be charged. The treatment pulls fluid and bacteria out of a wound to help it to heal better, but we'll get into that a little bit more as we move forward. Can I just quickly tell you about the very first time that I saw this dressing? I was 20 years old in 2006. It was a female patient, pregnant, with a burns wound on the palm of her hand, and she had the KCR machine with a black foam, and it was just sitting on her hand. I didn't even see the tubing. I ran out of there so fast. I was so scared. And this is one of the reasons why I decide to do this type of videos. Sometimes we send patients with these machines and they have no idea what's going on. They're a little bit scared, but they don't want to say too much. And also there are people that are new in this industry of medicine, like new physios, new nurses that are going to be seeing these machines for the first time. And I just want to give them a little bit of insight. So what type of wounds would we probably choose to treat with this type of dressings? One would be the His wounds. These wounds would be a patient went to theater and they've got a suture, and for some reason, most of the time due to infection, suture line opens and now they have an open big wound in that area. That's a dehisced wound. Diabetic foot ulcers, because they take longer to heal, and using negative pressure helps them to heal faster, control infection, and also promotes granulation. Pressure injuries, it would be probably stage 3 or stage 4, but with stage 4, obviously, there are precautionary measures that we have to take into consideration. Surgical sites would be small wounds. After theater, the wound is still sutured, but you find that there's a lot of fluid that's collecting under the suture line and it's draining a lot. And for those people, we would normally use that small dressing, the white one that I referred to at the beginning. Necrotizing fasciitis, and also it could be partial thickness burns, hard to heal chronic wounds, and graft wounds or flaps. And so what are the benefits of negative pressure? It keeps the wound moisture levels just right. It controls infection. There's a rapid increase of granulation tissue. That basically means that if you have a big hole wound, then that hole fills up very fast with tissue. It's an advanced dressing that doesn't have to be changed often, and this is because every time you open a wound to do a dressing, exposing it reduces its healing time. It takes longer after you close it for the process to continue. It brings wound edges closer together. Therefore, at a later stage, once you have healed, you'll have a smaller scar compared to if you had used the normal dressings. And yes, wounds do heal faster if the dressing is used and maintained correctly. And it gives patients time to carry on with their normal daily lives. That is because they don't have to worry about scheduling appointments to change the dressings, and you can just keep the dressing on, put the machine aside, and carry on with your normal duties. Go to work if you need to, live normally. And it also reduces swelling. If there's a lot of swelling around the wound sites, then it reduces inflammation and swelling. So here's a fun fact. The negative pressure method was first used in 1985 to treat infected wounds by a Soviet surgeon named Dr. Neil. I don't want to say the surname in case I butcher it. And then the modern negative pressure wound therapy system came into being in the late 1990s. Okay, let's talk application. This is what negative pressure normally looks like. Not always on the leg, depends where your wound is. You have the foam on the left there. The foam is attached to the wound site. And then on top of the foam, there's a transparent film, and then you cut a small hole. You connect the tubing. The tubing connects the dressing to the machine. Top right, the machine has a canister, which is a plastic bottle-like container that will keep all the drainage that comes out of the wound bed. And don't worry about the settings. The wound care nurse will set the machine herself. So this is the wound that you're going to be seeing as I explain the procedure. But if you are a clinician, you can already see that there's some challenges there. There's an exposed bone, there's a tunnel, and there's ishka. And this is why this dressing must only be done by a clinician. This wound is much better, plain and simple. Cleaning the wound is the most important. And you not only clean the wound, you clean the surrounding skin as well. And on top of that, the surrounding skin, you have to use protective barriers, because the taping, the transparent film that we use on the skin can damage the skin, especially with each and every dressing change, when you have to peel out that adhesive transparent film and reapply it. So using barrier creams or spray, not creams, sorry, using barrier wipes or sprays, I'll show you a picture now, helps to protect that skin. This is the more common type of barrier spray and wipe. Here's another one. Here's another one. There are also familiar wipes that you use to remove the transparent film, because if you don't protect that surrounding skin, you can easily expand the wound size. So you must protect that surrounding skin. I cannot stress that enough. So the dressings and the materials come separate, and we would have to cut them to size to fit the wound shape and everything, and we would have to assemble the machine. When you plug the wound with foam, you want to make sure that there's a lot of foam, because if the foam is thin, it might cause over collapse and prevent the fluid from moving away from the wound base. You also want to make sure that the foam fits the exact size of the wound and does not overlap onto the surrounding skin, because the foam can macerate the skin and can cause skin injury on the skin that is surrounding the wound that does not have a wound. So you have to protect that skin. You can also add a little bit of the transparent film if you are afraid that the foam might be touching. The next step is to apply the transparent film, and it must overlap the dressing and at least extend about 2 to 3 centimeters of the foam. I'll do a part 2